It's certainly an honor and a pleasure on behalf of Abdul, Fred, Jim, and the entire Insight START study group to present the results of START. As you know, evidence for initiating antiviral therapy at CD4 cell counts above 350 primarily comes from large cohort studies, of which the findings has not been consistent among them. Therefore, there is uncertainty about the effect of early ART on serious non-AIDS conditions, and most of the morbidity at high CD4 cell counts is due to these non-AIDS conditions. The absolute risk of AIDS is low at higher CD4 cell counts, and thus the adverse effects of early ART could easily outweigh the benefits of reducing the risk of AIDS. In response to that, the START study was designed. It recruited HIV positive individuals who were ART naive and with a CD4 cell count above 500 cells per microliter. And these people were randomized to the immediate ART group and starting treatment immediately, as opposed to deferring treatment until the CD4 cell count has declined to 350, AIDS developed, or there was another condition that mandated the initiation of treatment. As you can see, there was 2,300 and a little more in each of those two groups. The primary composite endpoint, which had a target of 213 events before the study was finished, is either serious AIDS or death from AIDS, or serious non-AIDS events or death which is not attributable to AIDS. And these events are CVD, end-stage renal disease, decompensated liver disease, and non-AIDS defining cancers. The study is worldwide. As you can see, 33% of the participants were enrolled from Europe, 25% from Latin America, 21% from Africa, 11% from North America, 8% from Asia, and 2% from Australia. 35 countries in total and 215 sites participated, of which 54% were from low and middle income countries. The 4,685 participants and their characteristics is shown on this and the next slide. The median age was 36, 27% were females, and the race reflected the different sites that included the patients, with 45% whites and 30% blacks. The mode of infection for being HIV positive was overwhelmingly sexual transmission, either among sex with men or heterosexual transmission. Only 6.6% were infected by other means. People were known to be HIV positive for a median of 1 year. 32% were smokers in enrollment. And given the young age, the Framingham 10-year coronary heart disease risk were only 1.9% in median. I've not shown the result of the two groups by themselves, but rest assured that the two groups were well balanced. The entry CD4 cell count was 650 as intended, a high CD4 cell count within the normal range. And you can see here the distribution of the CD4 cell count in the different strata. There was 11% of patients who entered the trial with a CD4 cell count of more than 900. The baseline HIV RNA was 12,759 copies per milliliter, and you can see that 32% had 30,000 copies or more at study entry. At this point in time, I just want to remind you of the START protocol, which was obviously written without any knowledge of interim data. And the protocol recommended early termination or modification of the trial only when there was clear and substantial evidence of a treatment difference. This particular statistical method was used to determine this, and the requirement was that both major components of the primary endpoint was favoring the same treatment, defined with a Z score of more than 1.5. The start DSMB recommended early termination with 59% of the primary events, 59% of the 213 events at the meeting on the 15th of May of this year. We informed investigators and participants on the 27th of May, and the closing date for the analysis presented here is the 26th of May of this year. At this time, the cohort had been followed for 14,060 person years, giving a mean follow-up time of 3 years, of which 24% of the participants had been followed for 4 years or more, and only 4.5% had not been seen in the last 10 months before the closure date. As intended in the early arm of the study, the take-up of antiviral treatment was very rapid, with more than 90% initiating treatment within the first couple of months, and then a few more adding treatment thereafter. Conversely, in the deferred arm, treatment uptake was more gradual, as intended, as people were progressing. Also on the slide is shown the proportion of people who had an HIV RNA less than 200 copies per milliliter. And the point of showing the two lines together is that they're virtually superimposable, implying that people who initiated on treatment was biologically suppressed thereafter. And this was equal for the two arms of the study. Overall, the proportion of follow-up time spent on antiviral treatment was 94% in the immediate arm, as opposed to 28% in the deferred arm. In the deferred group, the median time to ART were 3 years, whereas it was projected when the protocol was designed to be 4 years. The CD4 cell count at ART initiation in the deferred group is displayed on this graph. Relative to the design, where we had projected that the median CD4 when people were starting treatment in the third arm would have been 330, it was actually 80 cell or so higher at 408. Some of you is probably interested in what type of drugs that patients were using. This is displayed for the 98% who initiated treatment in the immediate group and the 48% who initiated antiviral treatment in the deferred group. As you can see, the preferred combination pill in both arms were tenofovir, emtricitabine, and efavirenz. 73% of the participants in the immediate group used efavirenz as part of their initial regimen, and somewhat fewer in the deferred group, as more people were using rilpivirine instead. In both groups, nucleoside backbone was predominantly tenofovir, typically combined with emtricitabine. As a result of the durable suppression in both arms, we saw robust increases in CD4 cell count, in particular in the early arm, as all people virtually were started on treatment very quickly. From the entry CD4 cell count here displayed as mean 700 and up to around 900 after a couple of years. In the deferred arm, we saw an initial decline as the natural progression of the HIV disease were allowed to happen in most patients, after which time it stabilized and increased slightly as more people were started on treatment. So in summary, in terms of the study and the way it was conducted, we had excellent retention, we had good adherence to antiviral treatment once it was initiated. We had early initiation of ART in the deferred arm than what we had projected before we saw the results. But importantly, as intended, there was large differences in use of ART, CD4 cell count, and HIV RNA during follow-up between the two groups that we compared. So now I'm going to show you the result, the major result of the study. There was 42 participants in the early arm, or 1.8%, that developed the primary composite endpoints in the immediate group, as opposed to 98 participants, or 4.1% in the deferred group. This resulted in a reduction of this composite endpoint in favor of the immediate group of 0.43, or a 57% reduction in risk. The estimate from a Kaplan-Meier plot after 4 years of follow-up in the immediate group was 2.5 as opposed to 5.3 in the deferred group. Of these people that developed the primary endpoints, 14 developed serious AIDS in the immediate group as opposed to 50 in the deferred, and 29 developed serious non-AIDS in the immediate group as opposed to 47. You'll quickly calculate that these numbers add up to one more, and this was because one participant in each group had both a serious AIDS and a serious non-AIDS event, and therefore contributed to each of the two components. Let me now give you the result of the two components separately. As mentioned, 14 participants in the immediate group and 50 in the deferred group experienced these events, serious AIDS events. This gave a reduction in relative risk of 0.28 or 72% reduction in risk. Of note, the separation in the curves only really became apparent after 4 to 6 months of follow-up, where most of the people in the immediate arm had started on treatment some months before. And after that, it continued, the two graphs continued to separate over time with a continued increased risk of contracting these events in the deferred arm. The types of serious AIDS events that occurred were predominantly TB, which occurred in 26 participants, lymphomas in 13, capices in 12, PCP in 6, disseminated herpes zoster in 3, and 4 others had other types of events displayed below in the slide. Of note, participants from Africa was disproportionately affected by TB as an endpoint, so 62% of the 26 events occurred among participants, the 20% of the participants that came from that continent. This is similar data for the other component of the primary endpoint, serious non-AIDS, affecting 29 in the immediate group and 47 in the deferred group, giving a reduction in risk of 39%, which was significant. You'll see that the curves are not splitting as quickly and as markedly as for the AIDS events, and there's a certain degree of pickup in the immediate arm in the later years of follow-up. The types of serious non-AIDS events that was explaining these events were predominantly cancers, which occurred in 9 participants in the early arm and 18 in the deferred arm. The number of people who developed cardiovascular disease was 12 versus 14, liver and renal disease 1 versus 2, and then there was death that occurred more frequently in the deferred arm, 13 versus 7. I'll come back and explain that. In terms of the cancers and cardiovascular disease, in participants from Australia, Europe, Israel, and the United States were disproportionately affected by these types of events, since 81% of the cancer events, 22 out of 27, occurred from participants that lived in those sections of the world, and 73% of the CVD events. At this time, we found it was important to give you the observed hazard ratio, as I was just explaining on the previous slide, for the overall composite primary endpoint, its 2 major components, and was comparing that to what was predicted when the protocol-stipulated sample size recalculation occurred in January 2013, as the sample of the entire study was increased from 4,000 to 4,600. The point of the slide is that, as you can see, there was a consistent, more marked benefit in favor of immediate arm observed than what was predicted, both for the overall composite endpoint and for the 2 components. Additionally, serious AIDS events as part of the primary endpoint occurred more frequently, 46% than what we had anticipated when the study was designed, 23%. And all of these factors together explains why the results were more marked, and therefore the study was disclosed and unblinded in late May. Let me now give you two other components of the primary endpoint. First, death, which occurred in 12 participants in the immediate arm, as opposed to 21 participants in the deferred arm, giving a relative reduction of 0.58 or 42% reduction. Although this was not significant, and clearly the study was not powered to address this as a separate endpoint. Of note, the death occurred after some time of follow-up. At least the separation, the apparent separation of the two curves only became apparent after a couple of years of follow-up. The type of death that occurred was primarily accidents, violence, and suicides happening in 4 and 6 participants in each of the two arms. Active AIDS disease occurred as a underlying cause of death occurred in 1 versus 4, cardiovascular disease 3 versus 1, non-AIDS cancers in 1 in each group, substance abuse in 2 in the deferred arm, and then there was 4 other reasons that is explained in the footnote below that all occurred in the deferred arm. Clearly suggesting that there was not a clear pattern that explained the fewer deaths in the immediate arm. The other component of the primary endpoint that we would like to show you specifically is cancers, which occurred in 14 participants in the immediate arm as opposed to 39 in the deferred arm, giving a relative reduction of 0.36 or essentially a 64% reduction. Of note, the benefit in favor of immediate arm was only apparent after 12 to 16-month follow-up, after which time you can see a clear separation of risk in the two groups of the study. This table gives you the overview of which type of cancers that occurred. It's a mix. Kaposi again and lymphomas was clearly happening less frequently in the immediate arm compared to the deferred. But there was also a number of other types of cancers which occurred in individual people without a clear picture, from hematological, cutaneous, and soft tissue type cancers that occurred numerically less frequently in the immediate arm compared to the deferred arm. As you probably will see from this data, many of the cancers that occurred are related to pro-oncogenic viruses, where there's other types of the cancers that were occurring and occurring more frequently in the deferred arm that at this point in time is not known to be related to an infection. Moving on to a presentation of subgroups. This is 4 of the total of 8 subgroups that I'll be presenting for you today. This relates to the age at study entry. And what you're looking at here is essentially the overall hazard ratio for the study as such, the 0.43, and then the hazard ratio in each of the subgroups, those younger as opposed to older than 36, and I think you will appreciate that these are virtually the same. Also, according to gender, similar benefit, according to race, similar benefit, and according to geographical region, again, similar benefit. There's a formal statistical analysis that was done for interaction, which consequently, as you can also visibly see, was not significant. Importantly, I'll give you a few more data on this. This was, over here is displayed the relative reductions. Over here is the actual rate in each of the subgroups, and I think not surprisingly, older people had a higher rate of the primary endpoint compared to younger people, but again, in relative terms, in both groups, that was reduced to virtually the same extent in people on the immediate arm. Also of note, the rate of the primary endpoint was fairly compatible in people from high income as opposed to low and moderate income countries. The four other subgroups that we will present on that were stipulated a priori was baseline CD4 cell count, and again, there was equal benefit irrespective of which CD4 cell count the patients entered the study with. Also, according to baseline HIV RNA, equal benefit irrespective of entry CD4 cell count, and again, equal benefit for smokers as opposed to non-smokers, and also equal benefit irrespective of tertiles of 10-year coronary heart disease risk, as you can see over here. And again, the p-values are consistent with the observed consistency. Again, not surprising, in people with higher 10-year Framingham coronary heart disease risk, the higher it is, the higher the event was in absolute terms, but again, in relative terms, there was equal benefit. The other thing to note is that as people had higher viral load, there was also an increase in absolute risk, but again, equal benefit in favor of the immediate arm. Moving on to other serious clinical events that was consistently collected in the cohort. First, grade 4 events. Before I go into that, I want to stress that these events were collected in all participants irrespective of use of ART, so the entire cohort during the entire follow-up period, these events were ascertained. In terms of grade 4 events, these were Division of Age grading system. Of note, this was only symptomatic events, so not laboratory defined grade 4 events. These events occurred in 73 participants in the immediate arm and 73 participants in the deferred arm, clearly no difference. We also collected unscheduled hospitalization as a marker of severe disease, occurred in 262 as opposed to 287 participants in the two-arm, giving a slight reduction, although it was not significant, in favor of the immediate arm. And if we then added on top of this also a death from any cause, you can see the numbers are increasing as you would expect, but again, still a slight reduction, although it was not significant. Finally, if we then added on top of this composite endpoint, the primary endpoint, then we are increasing the number of participants with events to 295 as opposed to 355, and here we see then the reduction, as explained, primarily driven by TB and by cancer, and this was significant in favor of the immediate arm. So no apparent toxicity that was seen more frequently in the early arm. On this slide is shown the most common grade 4 events, unscheduled hospitalizations of death from any cause. These were bacterial infections, bone or joint injuries, depression mode disorders, unspecified infections, injuries that was not else classified, suicidal as self-injurious behavior, not else classified, and viral infectious disorders, not else classified. Not else, the whole terminology, as many of you are probably aware, is derived from the METRA coding that was applied here. Of note, the rate of these components of this occurred similar, except for one of them, namely the first one, bacterial infections, which occurred less frequently in the immediate arm than in the deferred arm. A reduction of 62%, which was significant in favor of the immediate arm. Moving back to the CD4 cell count, as already explained and here displayed in a different way, this is showing the change in mean CD4 cell count from study entry. Oops, I'm losing the curve here. There was an overall estimated difference in CD4 cell count between the two groups of 194 cells. If we then, rather than looking at the CD4 cell count at study entry, but actually is looking at the CD4 cell counts that was measured in participants during follow-up, and therefore we are focusing now on what we call the latest CD4 cell count. Not surprisingly, if you stratify a follow-up time according to the latest CD4 cell count, substantially more follow-up time was spent at high CD4 cell count in the immediate arm compared to the deferred arm, although most of the follow-up time in both of the arms of the study were spent with a CD4 more than 500, giving the study entry CD4 cell count being high to begin with. So therefore, we're really assessing the primary endpoints and its components in people who have a CD4 cell count mostly above 500, and that's important to emphasize. Equally important, it's important to emphasize that if you just focus on people that live their life with the latest CD4 above 500, the proportion of the primary events that occurred in the immediate arm, 88% of the events occurred in people who lived their lives with a CD4 more than 500 and 59%. So most of the primary events occurred at high CD4 cell count, and during that period the event rate of the composite primary endpoint was reduced in favor of the immediate arm, 0.6 per 100 person years as opposed to 1.1. The other thing to emphasize on this graph is displayed over here. As intended, we clearly didn't want people to progress below the 350 cutoff. This was an indication for treatment as per protocol, and we are very happy to observe that only 5 of the 94 events in the deferred arm occurred in people with the latest CD4 less than 350. So in summary, 1.8% of study participants in the immediate and 4.1% in the deferred group experienced the primary outcome being serious AIDS events, serious non-AIDS events, or death. This means in relative terms a 57% reduction in risk. This was evident for both serious AIDS and serious non-AIDS events, although it was greater in magnitude, relative magnitude for serious AIDS events, and was predominantly driven by tuberculosis and cancers. This benefit was consistent regardless of age, gender, race, the region of the world, the CD4 cell count and the HIV RNA viral load at study entry, as well as the two risk factors I showed you, but also others I could also show you for serious non-AIDS events. Most events occurred at high CD4 cell count, as I just showed you, also in the immediate arm, despite antiviral treatment, including AIDS events, and this clearly indicates that HIV-induced immune deficiency occurs early in the course of HIV disease, and that the CD4 cell count do not fully capture this. Finally, we can conclusively state that the safety outcomes are similar, if not in favor of the immediate arm. As a consequence, on behalf of the study group, we are happy to conclude that combination antiviral therapy should be recommended for all HIV-positive persons, regardless of their CD4 cell count. As such, the START study results align the benefits of ART to the HIV-positive individual to the benefits of ART to reduce the risk of viral transmission from HIV-positive persons to non-HIV infected individuals. We feel that there's at least three important perspectives from the START results. Firstly, it reinforced the need for further research to identify novel markers for impaired immune function, We cannot rely on the CD4 cell count to fully and adequately capture the immune deficiency that HIV is inducing, in particular in the early course of the infection. It also speaks to the need for developing other treatments for HIV infections beyond ART that can repair the residual hole that even early treatment is not able to fully clarify. More generally, the START results reinforce the need for health systems to improve programs to diagnose HIV infection and link those diagnosed to care. And more globally, it supports the goals to expand the use of ART to all HIV-positive persons in order to improve their health and to reduce transmission of HIV infection. There's many, many thousands of people to acknowledge, but first we really, on behalf of the study, want to acknowledge the 4,685 study participants that put their lives into a study over many years to clarify what we thought was, and still think it was, a critical study in which we are now happy to have conclusive results on. Thank you. We also want to acknowledge the START study site research staff at the 213 clinics that stayed put with the ability for the study to give clear answers. We also want to acknowledge the Insight International Coordinating Center staff, as well as the Coordinating Center at University of Minnesota that also served as a study sponsor. We want to acknowledge and appreciate the funding, the primary funding from the Division of AIDS at National Institutes of Allergy and Infectious Diseases at NIH United States, as well as the many other NIH institutes that were providing support for the study, as well as the international, mostly government funding sources that also was providing a component of funding for the ability to conduct this study. Finally, we created a central drug repository, asked the pharma companies to donate drug into this, and I'm very, very grateful for that collaboration and that donation that allowed us to distribute drugs across the world to ensure that the people had full access to the treatment, and also that the companies have graciously accepted, as we continue to follow this valuable cohort in the future, that the central drug repository will remain open. Finally, it's always a pleasure to give a talk on behalf of a big study group, but I think it's even a bigger pleasure to be able to tell you all that if you missed some of the points, we're happy to take comments, of course, but for those who really want to dive deep into the data, why don't you go ahead at the New England Journal of Medicine website. They just this morning released the article itself, 13 pages, as well as a 29-page web appendix that contains much of the data that I've been presenting and a lot more. Thank you very much for your attention.